Polymyalgia rheumatica is an inflammatory autoimmune condition that is characterized by inflammation affecting the shoulders and the hips. It is mainly caused by inflammation of the bursa and the tendons. The bursa are little cushions that sit between our tendons, and if they get inflamed, then that can cause significant pain and stiffness, particularly around the shoulders and the thighs. The signs and symptoms of polymyalgia are mainly stiffness. Stiffness is mostly in the morning, and it can last for over 30 minutes, sometimes several hours. The stiffness can lead to restriction of movement. So, for example, patients can complain that they are unable to wash their hair or sit up from the chair because they're feeling significant stiffness. Pain is also a feature, although it is less common than stiffness itself. And as a result of these symptoms, patients can sometimes complain of feeling very tired, fatigued. Sometimes patients have lost a bit of weight in that time. And very rarely, it can cause some fevers and more constitutional symptoms like feeling a bit sweaty and generally unwell. If polymyalgia is left untreated, it can cause some complications. In general, the main complication is increasing stiffness and immobility, so loss of function. The other complication, which is a rare subtype, is sometimes it can progress to an inflammatory arthritis, where the joints also start getting inflamed, not just around the shoulders and the thighs, but in the fingers and toes, and it can become something like rheumatoid arthritis. In addition, some patients with polymyalgia rheumatica can also progress to develop a condition called temporal arteritis, which is inflammation of the blood vessels, particularly the ones around the head and around the eye. It is a sister diagnosis to polymyalgia rheumatica, so it doesn't happen to all patients. I think it's about 10% or so may develop this, and it's very important that this is recognized early, as this counts as an emergency if it does develop. So polymyalgia rheumatica is diagnosed predominantly based on the history of stiffness in those areas that I've mentioned, together with an examination which confirms the evidence of this, brings in the diagnosis. To support the diagnosis, I often request blood tests, and that would check the inflammation markers. So the blood test will show signs of inflammation, and rarely we look for the complications if suspected. So, for example, if a patient is struggling for a long time and there are other symptoms elsewhere, such as change in bowel habit or respiratory symptoms, then we may look at investigating those separately as well. The good news about polymyalgia rheumatica is that it is exquisitely responsive to steroid treatment. So steroids is the main focus treatment option in this condition. In general, we start on a relatively low dose, around 12.5 to 15 milligrams of steroid. And the expectation is that patients should feel much better within 48 hours to 5 days. As a rule of thumb, I think if patients don't respond or don't feel better with the steroids, then probably the diagnosis is wrong and we should think about an alternative. So essentially, it is a very treatable condition. I suppose perhaps more complicated, though, is that this requires long-term steroid use. So in general, it requires a very slow reduction in the amount of steroids that I give. So we start off with, for example, 15 milligrams, then over a month, it goes down to 10, and then every month we reduce it by 1 milligram or so. So in general, patients tend to require steroids for at least 10 months, but sometimes up to 2 years. Obviously, this is on a weaning regime, so the dose does decline over time. But it's important to remember that steroids can have multiple side effects, and it's important to try to mitigate these with different things. For example, we often give bone protection with calcium and vitamin D together with the steroids. We also give a stomach protection option to prevent heartburn that often steroids can cause. So the management of this condition is predominantly with this approach. So in general, I tend to follow up patients quite quickly after I start them on steroids. For example, I would arrange a follow-up within 2 weeks to 4 weeks to make sure that the patient is responding. Because as mentioned before, if they're not, then it's important to think about alternative diagnoses and other possible complications. After that, follow-up would be once every 3 months to 6 months, just to make sure that the gradual reduction in steroids is effective. Very rarely, patients may find that they are struggling to bring down their steroid dose down to safer levels. And if, for example, they maintain on high levels of steroid, I would have to then introduce an alternative medication, which is a long-term immune therapy so that we can come off the steroids. Steroids, if taken too long, can cause long-term complications, and we don't want that. And that is where we would think about adding in alternative treatments. And so it's important to keep track of things. But in general, patients tend to wean the steroids with no real problems. And over the course of the 10 months to 2 years, they come off steroids and the condition does not come back.